as was mentioned, I'm Brian Chicoine. I'm the medical director. This is our clinic. It's on the campus of Advocate Lutheran General Hospital, which is a Chicago suburb, but not too far from O'Hare Airport, for those of you that have been to Chicago. And we have seen over 6,000 adolescents and adults with Down syndrome over time. And periodically we'll get asked, what have you learned? And that's not certainly something I can share in a brief elevator conversation, or certainly even do it complete justice in 90 minutes that we have here today. But I'll really just scratch the surface. So, but I think one thing that's really important is to understand how little we knew when our clinic opened 32 years ago. And so really our advantage has been that we were willing to listen to people with Down syndrome and their families, and we were very grateful that they taught us so much. They're really the experts, and we really appreciate being able to learn from them and participate with them in achieving their health goals. So an awful lot has changed since our clinic opened 32 years ago, including the doctor. This is me in 2000. If you look over my right shoulder, you'll see that Sydney Harbor. That's our oldest daughter, who's now 38 and has 2 children of her own. We were there for the 2000 torch carrying ceremonies. She was in an orchestra that got to play in some of the events there in Sydney, as well as in Perth. So we had a real good time. But really the focus today is what has changed in Down syndrome, not so much what has changed in the doctor, although you can tell that a little time has gone by since 2000. So today, people with Down syndrome are living longer and healthier than any time really in history. And you can see from that picture is who we call Lucy. That's not a real name for privacy purposes. She died at age 83. She was a woman with Down syndrome and lived to be 83. But you can see when I had a great uncle Leo, who was born in 1907 and had Down syndrome, although that's not what they called it at the time. His life expectancy was about 8. And then when I graduated from medical school in 1984, the life expectancy of people with Down syndrome was about 28. And now in the United States, in the Caucasian population, it's about not quite 60. So you can see just a dramatic change in the course of, really the course of a few generations, how much it's changed since I graduated from medical school. Certainly, it's been a real privilege and honor to participate in seeing so many more people with Down syndrome become adults and living longer. A major reason for that is that the ability to treat congenital heart disease. So, in the past, up until really the mid to late 70s, even early 80s, the ability to treat congenital heart disease, the heart disease that kids with Down syndrome are born with, was not available, and so many of those children unfortunately died in infancy, and now they're living out into adulthood, which is just a huge change. And so not only are folks living longer, but there are just many more adults than there were in the past. So in the United States, it's estimated that there's somewhere between 210 and 220,000 people with Down syndrome. And more than half of them are age 20 and older. And then similarly in Australia, it's estimated there's about 13,500 people with Down syndrome, and nearly 10,000 of them are greater than 20. So you can see it not only are the numbers up, but the number of adults and the percentage of adults has increased dramatically in the last few generations. So what are some of the things that we have learned about the health of adults with Down syndrome in those 32 years since the clinic opened? Well, we know that unfortunately there are quite a number of health conditions, what we call co-occurring health conditions, co-occurring to having Down syndrome, that are more common in people with Down syndrome. Things like thyroid disease, both under and overactive thyroid conditions are more common in people with Down syndrome. Anxiety, obsessive compulsive disorder, we see more commonly. Depression, unfortunately. Obesity, we see more pneumonia. And part of the reason for that is we see more swallowing dysfunction in people with Down syndrome. There's a number of skin conditions that are more common. Gum disease is more common. Heartburn, reflux, more common. Celiac disease, which is the sensitivity to gluten, which is a protein in wheat, barley, and rye, is more common in Down syndrome. Really, all autoimmune diseases are thought to be more common. So any condition in which the immune system, in a sense, attacks its own, our own body, and causes a condition. So type 1 diabetes, for example, diabetes that's more commonly seen in onset in children, certain form of autoimmune arthritis, inflammatory arthritis conditions, and a number of other conditions that are more common. Constipation is more common, as are seizures. Atlantoaxial instability, which is the slippage of the first vertebrae on the second, and it can pinch the spinal cord. That's significantly more common in people with Down syndrome. As are vision and hearing problems, and sleep apnea, significantly more common. Upwards of 70, perhaps 80% or more of people with Down syndrome have sleep apnea. And that's in people with Down syndrome, it tends to be obstructive sleep apnea, although not exclusively. And what that is where as someone breathes in, the airway closes while they're sleeping, and so they're not moving the air the way they would normally, and their oxygen levels may decrease, and their sleep is often disrupted. So that can be a very problematic condition. And then, as I mentioned, congenital heart disease. 50 or perhaps a little bit more percent of individuals with Down syndrome have born with heart defects, whether it's a hole in the heart or an abnormal valve. There's a number of conditions that people with Down syndrome more commonly have. And then, unfortunately, which we'll talk a little bit more about in a moment, Alzheimer's disease is significantly more common in people with Down syndrome and occurs at a younger age, unfortunately. So a number of conditions that are more common, and there are others, and you've probably seen with that. I'm just giving you a little bit of a list here. But it's also be perhaps less recognized is that there are some conditions in Down syndrome that are less common. Many solid tumors, such as breast cancer and colon cancer, stomach cancer, all much less common in people with Down syndrome. Atherosclerotic disease, the hardening of the arteries, if you will, plaques building up in the arteries of the heart that cause heart attacks or myocardial infarctions, significantly less common in people with Down syndrome. We see very few heart attacks in the individuals we see in our clinic. And then hypertension or high blood pressure, significantly less common. I think we may have seen about 5 people over over 32 years, over 6,000 people that have high blood pressure. So it's very uncommon as well. So a number of conditions that are also less common, and understanding that there are conditions that are more and conditions that are less common was part of the driving behind. I was fortunate enough to be part of the group that wrote the first set of global medical care guidelines, and we're working on the second set at this point. But those came out several years ago, and ultimately there was an article published in the Journal of the American Medical Association. And when you get the slides, if you click on that link to the Global Down Syndrome Foundation webpage, there's not only the article, but there's also versions that are more health family, I should say, more family directed rather than a medical article. And so certainly welcome to take a look at those and see what the recommendations were. And again, some of those are based on some conditions that are more common that we should be screening for, where we might not screen in somebody else. And some of those that are less common, perhaps we're not going to screen for someone with Down syndrome, that it would be recommended to screen in someone else. Again, we're not trying to shortchange the healthcare of people with Down syndrome by not screening for certain things. But if something's really very uncommon, putting people through the risk of the screening may well not make sense. And so that's the thinking there. So we really want to focus on the things that are more common, and perhaps less focus on the things that are less common. Every test has a potential for complications, and we want to make sure that we're doing the ones that really get us the most information and have the most benefit to someone's health. One of the other things that we've learned in the 32 years is what I call the 2 syndromes. And this actually was a lesson that I really began to appreciate very early on in after the clinic opened in 1992. So just looking at the pictures, the picture on the left there is a picture of we had the woman in the background is Sheila Hebine, who was the executive director of our local parent group at the time, and they put together a aerobics videotape back in the mid 90s, and that's the four people that are in the video, and so that goes way back. And then the picture on the right is we had good fortune of taking a number of folks with Down syndrome to a Chicago Bulls game. Now, Chicago Bulls is a basketball team. Perhaps you might know it well most because Michael Jordan played on the Bulls many years ago. Anyway, we had the good fortune of taking a group of people to a Chicago Bulls game. That is Artis Gilmore in the background. He is a retired Bulls player. He is 7'6", and you can imagine the height difference for some of individuals with Down syndrome compared to Mr. Gilmore. But again, there's more to this than just the differences in the pictures. One of the things very early on we found is particularly as we looked back in the early to mid 90s, and we were looking at the individuals in our practice who were born in the 1940s and 1950s, and comparing to them to the people that were born in the 1980s and even into the 1990s as time went on. And so really, although the genetics was presumably the same with an extra 21st chromosome, the individuals tended to be very different. And a lot of that had to do with what we really thought had to do with opportunity and education and healthcare and social interaction and social acceptance. In the early days of the clinic, we might see individuals that, which was not uncommon back in the 40s and 50s, for someone with Down syndrome to really not be taken out of the house. And we saw individuals who spent the bulk of their life indoors and not participating in the community. And so really these opportunities and the opportunity for person education and to be employed and to attend school and to get good health care, it made a tremendous difference. So we call that the two syndromes. So even though again the genetics were the same, really the outcome was just so was becoming so different based on the opportunities for good health care and social opportunities, et cetera. And so really we marvel at how far people have come in the 32 years since the clinic opened, and wonder how much things are going to change in another 32 years. Another thing that's changed, certainly in our approach, is when the clinic was opened, we really looked at it as a clinic for people with Down syndrome. And over time, we really look at it more a clinic with people with Down syndrome. And that's based on the sense that, first off, we think about what we're trying to do, and that's to promote health. And so we use the World Health Organization definition of health, and that's that it's a state of complete physical, mental, and social well-being, and not merely the absence of a disease or an infirmity. And we really feel strongly that people with Down syndrome should be active participants in their health care. And that we also feel strongly that health promoting behaviors have a positive impact on the quality of a person's life and their health. And we've seen that over and over and over in the individuals with Down syndrome that come to our clinic. So really the shift from a question of can people with Down syndrome participate in their own health promotion, we would think of that as old thinking, to more, how can we encourage the participation of people with Down syndrome in their own health promotion? We know that people can participate. We just need to make sure we're figuring out ways that we can encourage them to do so. And certainly there's a wide range of skills and reading abilities and attention and other things in individuals with Down syndrome. So it really is not going to be one size fits all, but we're continuing to look for the ways that we can encourage people to participate in their own health. And we know that people with Down syndrome tend to be more visual learners. And one of the things that we know, the book there on the right is called "Seeing is Believing." It writes about a model called self-modeling, in which individuals are videotaped doing the desired behavior or the desired health behavior, whatever, and then they are shown that video. And that because it's themselves, it has a particularly reinforcing benefit to promote whatever activity we're looking at. So I'll just give you a brief example of how we used it. We've used it a number of times, but this is just one example. We had a gentleman with that had Hirschsprung's disease at birth, and Hirschsprung's is a abnormality of the colon that he was born with, and required to have a significant chunk of his colon removed. And unfortunately, one of the complications of that is oftentimes people will then have incontinence of stool. And so he had learned how to, maintain continence, and he was doing pretty well. But if he had to go, he had to go, and if he delayed, he would tend to have an accident. And so he was included in school, and just for a 17-year-old boy in school to have accidents certainly was not not socially acceptable, we'll say, and he was getting some grief for that. So what we did is, we knew that what was happening is that he was, if he was engrossed in something, that he would sort of ignore his body signals, and then it would get to a point where it was too late. And so we had him make a video at home. His family just took their phone, and he was sitting at a desk, doing homework or whatever. And then he looks up in the video, and he says, I feel like I need to go to the bathroom. And he immediately walks away out of the camera, away from the table, presumably to the bathroom. And just as a reminder to him that he should, not try to hold it if he needs to go. And so he watched that every morning for a few weeks, and it kind of sunk in and really reminded him, and it really solved the problem. Several weeks went by, and it started to come back, and so the family brought out that video again and showed it to him every morning for several days, and again the problem solved itself. So they do that periodically if he is kind of backsliding, if you will. They'll just show him the video and as a kind of a preventative, and that's worked very well. So that's called self-modeling, and that can be used for all sorts of things. Second best, and again, part of the reason self-modeling works is because you are seeing yourself. You're seeing someone that looks like you and talks like you, and in fact it is you. And self-modeling, peer modeling is second best, and that's where the individual tends to look like you and talk like you. It isn't you, and that's why our health promotion videos all have all the actors and actresses have Down syndrome. And so you can see just some of the examples there where individuals are encouraging healthy behavior. And so we use that as encourage individuals with Down syndrome to watch those videos in whatever, and we have a number of them, whatever the healthy behavior that we're seeking or they're seeking. And so that's called peer modeling, and that tends to work. And one of the, just for me, I watch those videos, and one of the things I note is, the talking is a little slower than I talk, but that's exactly the point. I probably talk too fast for many people with Down syndrome, and the individuals that are speaking more at the speed that they're listening. So it tends to be a very effective tool to promote healthy behavior, or health behaviors, I should say. And so similarly, as part of that is the fact that people with Down syndrome tend to be better visual learners than they are auditory learners. And so we have, in addition to the videos, we have a number of pictures, visual aids to promote healthy behavior. Taking my thyroid medication, getting an X-ray. What does that take? Healthy eating visual, self-talk visual, getting my earwax cleared out. Just things that kind of help prepare people for appointments, or encourage them to do like taking your thyroid medication every day, encouraging them to accurately take their thyroid medication on a daily basis. All of those are available for free on our website, and that's our website there. And so we can see it's divided into 3 groups: people with Down syndrome, for families and caregivers, and then healthcare professionals. And again, the section on people with Down syndrome heavily weighted towards videos and visual aids, visual prompters for healthy behavior. And then another thing that we've really come to appreciate is what's called dignity of risk. different topic than what we were just talking about. But what dignity of risk is, it really is not. It actually was about before was out there before the clinic opened. But it's something that over time that we've learned more about and tried to put more into practice. So what dignity of risk is, it's a respect for an individual's right to make their own decisions, with allowing a person to participate in a broad range of desired activities, and to expose themselves to potential consequences or learning opportunities. So traditionally in healthcare, decision-making for people with Down syndrome has been a more paternalistic approach, done in a positive way, with good intentions as a benevolent assurance of safety for people with intellectual and developmental disabilities. So with a focus more on safety than on autonomy, making one's own decisions. So in 1972, Robert Persky, a theologian and a disability rights advocate, wrote that, and I'll paraphrase since he uses the older term for intellectual disabilities, but I'll paraphrase here. There is a growing interest in granting people with intellectual disabilities their fair and prudent share of risk-taking in their daily living. Denying individuals with an intellectual disability exposure to normal risks commensurate with their functioning tends to have a deleterious effect on both their sense of human dignity and their personal development. And so again, giving people an opportunity to make decisions and then learn the consequences is really what the thinking is behind that. Unfortunately, oftentimes this gets defined as either A or B. Excuse me, I'm sorry. A or B. So, it's either unrestricted freedom, complete dignity of risk, let people do whatever they want, or no freedom. We don't let them do, we don't let them, we make all the decisions for them. What we promote and what others have talked about is the middle ground, where we want to encourage people to have freedom in their choices, but we want to also that does not excuse us from providing education or encouraging healthy behavior. So yes, the individual wants to eat whatever they want and gain weight, and that's in a sense their right. But that doesn't eliminate our need to continue to try to encourage them on healthy behaviors, healthy food choices, and guide them and the things that are more healthy. And so really it's not just an A or B, and there's this middle ground where we really encourage people to learn more about the decisions that they're making. So we had an article published a few years ago about dignity of risk, and this case, and if you look at the article, it's a very challenging case where the individual had severe swallowing problems. And so we were looking at the choice of the unrestricted freedom, let him eat whatever he wants and keep getting pneumonias, or no freedom, not put a feeding tube in him and not let him eat at all, or in the middle ground was really allowing him to eat, letting him eat, but to continue to encourage the diet that was most likely to be healthy for him. And least likely to cause him to aspirate and get pneumonia. And so really the education piece in the middle is so important. I've heard over many years, some of our folks that live in residential facilities where we're trying to help with a healthy behavior, and the staff doesn't support that. And they say, well, he has his rights, which I agree with. But that, again, we want to encourage education and teaching and example. We find that example is a very important thing. So folks with Down syndrome will often imitate what they see around them from a healthy behavior standpoint. So if everyone else is eating healthy and exercising, we find that in general the person with Down syndrome is more likely to do the same. So let's look ahead here a little bit. So what are some of the concerns that people are sharing with us? So we get lots of calls from all over, and we're hearing two things. One is people looking for healthcare for their son or daughter with Down syndrome, or their brother, sister, as the case may be. Occasionally someone with Down syndrome will reach out, but it's often a family member that's reaching out. And as we hear their concerns, there's two main issues. I mean, there's other issues, but there's two main issues. One is that they're looking for a provider that will treat the person with Down syndrome as a person with respect, and they find sometimes that's difficult to find. And the second thing is they're looking for a healthcare provider, healthcare professional that has more knowledge about caring for people with Down syndrome, that oftentimes the individual, particularly in the adult world, doesn't have the knowledge to take care of the person. So one of the very interesting article by Dr. Iazzoni, who's at Harvard at Mass General, she did a survey. This is done in the United States. She did a survey of 714 practicing physicians in the United States, and 82, almost 82.5% of them felt that people with significant disability have a worse quality of life than non-disabled people. And about 18% strongly agreed that the healthcare system often treats people, or patients, or people with disability unfairly. And only just over half strongly agreed that they welcome people with disabilities into their practices. So we, significant, if you will, a bias against taking care of individuals with a disability in medical practices in the United States. And I suspect that this is not terribly different in other places as well. And then another follow-up survey, they found that less than 41% of physicians were very confident about being able to provide the same quality of care to a disabled individual as they were to someone else. And so, again, sort of these families, what their families are telling us, that it was borne out by these studies, that finding a physician that is willing to take care of individuals with Down syndrome or other disabilities, and provide them respectful care, but also that have a good knowledge about being able to provide that care. So families' perception, it was borne out by these studies by Dr. Iazzoni. So, and we have certainly seen other ways that individuals with Down syndrome are biased against in the healthcare system. So there's an article we wrote during the pandemic, and we called it Ableism at the Bedside: People with Intellectual Disabilities in COVID-19. So ableism is the belief, like any other ism, it's the belief that the quality of a life or worth of a person with a disability, in this case, based on their abilities rather than their race or culture or other things. In this case, it's based on their abilities. The belief that the quality of life or worth of a person with a disability is inherently less than that of a non-disabled person. And so that's ableism. That's the definition of ableism. So in our case, there was a woman with Down syndrome and early Alzheimer's disease in her early 50s that was admitted to our hospital during COVID. And as she got admitted, I talked to her and her family, and they requested, in addition to full treatment, they requested that if she got worse, they would like her to be, if necessary, put on a breathing machine, put intubated and put on a ventilator, and if her heart were to stop, to CPR. So what we call in the States a full code status, and admit her to the ICU if appropriate. So we had that discussion. That was all documented in the chart. And then unfortunately, in the first 24 hours, her condition did deteriorate, and she did get admitted to the ICU. Unfortunately, she never got intubated, and she never coded. Her heart never stopped. But there was a lot of pressure day in and day out. I would go see her, and along with the intensivist team who was taking care of people in the intensive care unit. And there was a lot of pressure from the intensive care unit folks encouraging me to talk the family and the patient into asking for a DNR status, a do not resuscitate status. And really, in a lot of conversation with the ICU team, was very clear that the driving force behind that versus someone else was that this person had Down syndrome. And so there was a real drive, a bias, if you will, against this individual getting full care based on having Down syndrome. So we see that that's just in the advanced directives there on the upper left there. We see that's just one area where there's bias. Certainly in the United States, the lack of provider training in caring for people, particularly adults with Down syndrome. Again, in the States, the lack of Down syndrome clinics. Inadequate mental health services. In the United States, we certainly have a shortage, particularly of mental health providers, and even a greater shortage for those that can and will provide mental health services for people with Down syndrome and other intellectual disabilities. There's bias in the area of transplants, where there's actually a case before our U.S. Congress now, looking at promoting, asking the people with Down syndrome not be biased against when they need a transplant, as it's been done in the past. And then there's something called diagnostic overshadowing, which I'll talk more about here in just a second. So a follow-up, certainly not a direct follow-up, but I also got to participate in this paper with based on our not based on it, but kind of a follow-up to our paper about the woman with Down syndrome that they were trying to make a DNR, even though that's not what the family wanted or the patient wanted. So this was a paper, and this was an observational study that was, or a large clinical database study, I should say, from 825 hospitals in the United States. And so we were able to get data from those hospitals and look at that retrospectively. And this is again during the height of the pandemic. And so particularly in individuals with Down syndrome and individuals without Down syndrome who were admitted to the hospital with COVID pneumonia. So they had COVID and had pneumonia. And for both people with Down syndrome and without Down syndrome, both had COVID pneumonia. But the people with Down syndrome were more than 6 times more likely to be given a DNR order than those without Down syndrome. So again, there seemed to be a bias against people with Down syndrome with regards to wanting to provide full care during the pandemic. And then another area that we see a significant bias is the issue of life expectancy. And I mentioned how life expectancy has gone up so dramatically in the last few generations, but it is starting to plateau. And this article here indicates, and I fully agree with it, that the life expectancy of people with Down syndrome is plateauing, very likely because of Alzheimer's disease. And we know, again, unfortunately, people with Down syndrome have a much higher incidence or prevalence of Alzheimer's disease, and it occurs at a younger age, and the age of death, and therefore is younger because of the Alzheimer's disease. So that really seems to have leveled off the life expectancy of people with Down syndrome around 60. We know that Down syndrome is the leading genetic cause for Alzheimer's disease. So some people, most people that get Alzheimer's disease, it's sort of sporadic. We don't know exactly why they got it, but there's clearly a subset of people that have a genetic basis to their Alzheimer's disease. And one of those groups that has a genetic tendency clearly are people with Down syndrome. And it's the largest group of people that have a genetic tendency towards Down syndrome. I was at a meeting a few weeks ago, and Hampus Hillerstrom, who's from Lumind IDSC, which is an organization here in the States, he reported that 17,000 participants have been studied in the research studies for some of the newer Alzheimer's medications that have come out in the last few years. And none of those participants had Down syndrome. So we're looking at the group that has the highest genetic cause for Down syndrome, but none of them have been studied in these new drugs. So again, unfortunately, another real bias there. And then another bias is what we call diagnostic overshadowing. And that's a term that really was actually coined around the issue of intellectual disability back about 30 or so years ago. before I knew the term diagnostic overshadowing, we would just call it, it's not just Down syndrome. And what we meant by that is, you may have heard me tell this story before. If you have, please forgive me. But a few weeks after the clinic opened in 1992, a mom called me and said, my son has a cough. He has been to the doctor 3 times, and the doctor keeps saying it's just the Down syndrome. And I said, well, I'm not familiar with cough being a symptom of Down syndrome, so why don't you bring him on in? And I listened to his lungs, and he had changes in the lungs consistent with pneumonia, and I did an x-ray, and he had changes on the x-ray consistent with pneumonia, and treated him with an antibiotic, and the cough went away. That's a very simple story, and almost too simplistic, but it's the point is important that there are people with Down syndrome can get, well, again, these co-occurring conditions. So it's not just all Down syndrome. And so if someone with Down syndrome has a pneumonia, that's treatable. If someone with Down syndrome has depression, that's treatable. Diabetes. And so we don't want to just say it's just Down syndrome, there's nothing we can do about it. That's what we see is unfortunately not an uncommon thing for people with Down syndrome. So I gave the simple story of a physical health problem, pneumonia, but it's even more common in the mental health arena. So for years, families would come in and say, he's been sad, and he's not wanting to do things, and he's not wanting to interact, and he's not sleeping well and not eating well. And I said, well, that sounds like depression. And he says, I know, but the doctor just keeps telling me that's Down syndrome. There's nothing we can do about it. And you treat the depression, and they get better. So it's even more common in the mental health arena. And conversely, actually, it's sort of we also see people with Down syndrome, for example, that do self-talk, and that's a very common thing in people with Down syndrome. And that often gets overdiagnosed as mental illness in people with Down syndrome, rather than just sort of a common characteristic that many of them have. So sometimes people get put on too much medication for what is perceived as a mental illness when it's actually just a common characteristic. Alzheimer's disease is another place we see a lot of diagnostic overshadowing of people with Down syndrome. And so we know, unfortunately, that, as I mentioned, that Alzheimer's disease is more common in people with Down syndrome. And so many times a person with Down syndrome will decline for whatever reason, and they go to see the doctor, and they're just told, well, it's just Alzheimer's disease. Nothing we can do about that. And so I can't tell you how many calls over the years I've gotten from families that say, my 20-year-old son went to the doctor because he's not doing as well, and he's been diagnosed with Alzheimer's disease. And I say, well, I've learned never to say never in medicine, because as soon as you say never, you're going to get a case. But that's a pretty close to a never. And so, look at the thyroid, look at the B12, look at sleep apnea, look at what's now called Down syndrome regression disorder. Look at depression, other mental health issues. Look at, could it be pain? I mean, there's lots of reasons, just like any of us, that people with Down syndrome can have a cognitive decline, and it's not all Alzheimer's disease. So all these things to consider, that there is other possibilities, these co-occurring conditions, and we just don't want to all blame it either on Down syndrome, or as they get older and they're having decline, all just blame it on Alzheimer's disease. And similarly, some of the other health conditions we see in people with Down syndrome. Well, for example, obesity is pretty common, unfortunately, in people with Down syndrome. But we just don't want to just throw up our hands and say it's just Down syndrome. What can we do about it? How can we work with diet and exercise and healthy eating? And now certainly we're beginning to look at some of the medication. How can we help with that? So again, just because characteristics are common, if they're a problem for their health, we want to make sure we're trying to address those. And then again, the lack of provider training, as I mentioned, and so we certainly, families and people with Down syndrome really encourage them to share information with their healthcare provider. Many years ago, I was a family physician in a smaller community, and had 2 or 3 people with Down syndrome in my practice, and frankly, I didn't really know too much about Down syndrome, and so it would have been that back then there weren't that much information to share, but it would have been lovely if one of the families that, or some of the families had shared some of the information that's now available with their provider and let them know that there's more information about people with Down syndrome available. And again, if a provider only has 1 or 2 people with Down syndrome in his or her practice, there may be some things that they don't know about. And so there's the picture on the left is the global guidelines we talked about, and then picture on the right is our mental wellness book that Dr. McGuire and I wrote, and is now unfortunately Woodbine House, the publisher, went out of business, and so we made it free, available online as a PDF, and it's available on our website. And then the Down Syndrome Medical Interest Group is available to provide information for healthcare providers as well, and so it's a relatively inexpensive membership, and certainly we have members that are not from the United States. We have a nice library on the Down Syndrome Medical Interest Group site. And then there's something called Project Echo, where monthly a group of Down syndrome experts get together, and someone has submitted a case. We're trying to get more and more community healthcare professionals to submit a case, and then the panel of experts, share information that might hopefully be helpful about the case. And the case is presented anonymously, so that no identifying information about the individual is provided. And then the healthcare professional can take that information, back home in a sense, and treat that individual. We have not had anyone from outside the United States present the case at this point, but there's no reason that we couldn't. Obviously, we don't know the Australian healthcare system like we do the States, but many of the issues would be the same. There's a duplicate slide there, so I'm going to jump over that. So clearly there are things we still need to work on, and I just talked about those, and hopefully through education and hopefully through people with Down syndrome being more out in the community, and it's all getting to know them better, and we can work with them and support them in their own healthcare journey. So we're not to the finish line yet, as we were there with at the end of a 5K that I ran with the 2 gentlemen with Down syndrome there. But we're we've come a long way in 32 years, and there's but still much to be learned. We do have, and again, I have a little phrase I call health equity through education, equity through education, meaning how can we improve the healthcare delivery for, and working with people with Down syndrome to improve their health, and I think education is one of those ways. And so on our webpage, we have our online resource library. We also have an email list where we share resources on a regular basis with the people that are signed up for on the email list. We have a Facebook page that has a lot of information we share regularly, as well as an Instagram page. And so if you're interested, hopefully one of those would be available, something that you would be able to get the information from, and we encourage you to use that, all free information. There may be some articles from journals that require a subscription that we don't have to share. We just share the general information about the article, and then you have to purchase that. But that's the small minority of the information that's on the website. That's unfortunately not under our control. And then one of the ways to learn more about what are the healthcare needs of individuals with Down syndrome is to see some of the data. How frequently some of these conditions occur. And this is a paper we had published a few years ago, and it's on the prevalence of common diseases in people with Down syndrome, so these co-occurring conditions. And then we did 3 papers follow up on more specifically on drill down a little bit more in mental health conditions, infectious disease, and endocrine disorders such like diabetes and thyroid. And so in the paper, it's what's called the odds ratio, and that's a term that refers to how much more likely or unlikely is it these to occur in people with Down syndrome. So if the odds ratio for someone with Down syndrome is 1, that means it's just as likely to occur in someone with Down syndrome as it is in someone without Down syndrome. If it's greater than 1, it's more likely for the person with Down syndrome to have the condition. And if it's less than 1, it's less likely for the person with Down syndrome to have the condition. And so there's a number you can see, as we talked about earlier, that some of the cancers that are less common, breast and cervix and colon. But then, as you're probably aware, in children, leukemia is more common, and then in boys, cancer, the testicle is more common. Then in mental health, we see some conditions that are more common, like depression and anxiety, and obsessive compulsive disorder. But substance abuse or substance use or substance use disorder is much less common in people with Down syndrome. See some of the other mental health conditions that are more common. And these slides were, you should have access to these. We shared those. And then you can see a number of endocrine conditions that are more common. The thyroid you see there, and gout, not technically an endocrine condition, but it is more common in people with Down syndrome. And then a number of the thyroid conditions. And then type 1 diabetes is more common. In our study, we found type 2 diabetes that we tend to get as we get older, often associated with being overweight. In our healthcare system, type 2 diabetes was less common in people with Down syndrome. There was a similar large study done in the UK shortly after ours was published, and they found in the range of 20s to, I think it was mid 40s or about 50, type 2 diabetes was more common, but at the younger and the older folks, it was less common. So again, some differences in the information, but I think there's more to be learned there. We know, unfortunately, some of the infectious disease issues are more common, although we see a number of them that were less common in this slide. But then you can see pneumonia is a significant problem, and then skin infections as well were more common. And then a number of gastrointestinal problems with obstruction of the intestines, esophageal disorders like reflux is more common, ulcer disease in the stomach or the small intestine, and then celiac disease is significant. You can see it's more than 18 times more likely to occur in someone with Down syndrome in our health system as it is in an age-matched. So someone that's matched in age and sex, gender, but otherwise has Down syndrome versus not Down syndrome, the person with Down syndrome was more than 18 times more likely to have celiac disease, so significantly more common. You see some of the neurological and orthopedic conditions that are more common. And then again, as I mentioned, high blood pressure, much less common. Stroke seems to be more common. There was actually a study done in hospitalized patients there in Australia several years ago that showed strokes being more common, and what they seem to be not completely but largely related to having congenital heart disease. That some of the late effects of congenital heart disease does put people more at risk for developing what are called embolic strokes, where they develop little clots inside their heart, and then they're flicked off, if you will, and they go into the brain. And so that's one of the reasons we recommend all our individuals with Down syndrome that we see at our clinic, and as part of the healthcare guidelines project as well, that all those folks are recommended to follow up with a cardiologist on a regular basis. What does regular mean? It depends on the individual, depends on what heart surgery they had, it depends on the status of their heart. But typically, at least every 5 years, follow up with a cardiologist, and sometimes more frequently, depending on their status, to check and make sure that they're not developing additional complications. Again, the atherosclerosis and the heart attacks much less common. And then something called moya disease, which is typically presents in children, although occasionally can present in adults, where there's an abnormality in the blood vessels, particularly in the back of the brain, and can cause strokes. Is another reason that people with Down syndrome can get strokes, and that's significantly more common in people with Down syndrome. Then again, we talked a little bit about the heart disease and the risk factors. And then just some other, we talked about swallowing being more common, a lot of eye conditions, and then we talked about sleep apnea being more common. We have a number of references that if you're interested in learning more information, please feel free to take a look at those. And then I'm going